certain cancers have better outcomes than diabetes does. So certain cancers like lymphoma, other cancers are completely curable. Diabetes we've only ever managed to achieve remission in diabetes and not actually cure it, because the genetic tendency to diabetes stays with you your whole life. It has so many other complications. You've heard about heart disease, stroke, amputations, nerve disease. It's the leading cause of blindness in the Western world. It's the leading cause of kidney failure. So really, if diabetes is not well controlled, an individual can have a really miserable life. And I'm so glad that in the last 10 to 15 years, diabetes therapy and education has really improved, that we're hopefully seeing less of those outcomes we did 20 or 30 years ago.
Welcome to the Motherhood Clinic, a podcast about caring for mothers after childbirth, led by clinical experience and real-life stories. If you're a new mom and ever asked yourself, is what I'm going through normal? Should I be worried? Or who should I ask for help? This podcast is for you. It's for anyone navigating those early weeks, months, or even years after having a baby. Each episode brings together voices from across the motherhood journey, from clinicians, experts, and mothers from all walks of life. We're here to help you feel more empowered in your unique motherhood journey. We believe in a better start to motherhood.
Thank you for joining us, Fareeha and Fiona. Today in the room, we've got two senior clinicians, and so we're going to talk about two key topics. One around gestational diabetes, what is it, why is it of impact, and what you can do about it. And the second, after this episode, will be around obesity. So in the room today, we've got Dr. Fareeha and Dr. Fiona. I'd like to hand over to you both to give yourself like the 1 or 2 minute overview of what you do, your background, and like, your relevance to this conversation. So Dr. Fareeha, if you'd love to hear your intro.
Hi, thank you so much. Thank you so much for the invitation. So I'm Fareeha. I'm a consultant in diabetes, endocrinology, and general internal medicine. I trained and worked in the NHS for 18 years. And then last year I moved to Dubai, where I am head of obesity at a big hospital group here. And currently my practice involves all aspects of endocrinology and maternal medicine. So I see pregnant women every day with diabetes, gestational diabetes, type 1, type 2 diabetes, thyroid disease, pretty much anything, and I see it related to hormones. And I also run an obesity clinic on the Palm Jumeirah. So I'm really excited for today's topic. You probably won't be able to shut me up. Important. These are really hot topics. Apart from what I do for a living, I think these topics are really at the forefront of people's consciousness, the media, social media. So I think we'll have a great discussion today.
Thank you. Fiona.
So I've probably introduced myself previously, but I have worked with Fareeha for about 2 years or so. She's been a fantastic clinician to work with. So we used to cover the type 1 diabetes clinic as an MDT clinic, together with a dietitian, a diabetes specialist nurse, and midwifery input. And we also had overlap with some of our very complex type 2 diabetes patients. And Fareeha is always at hand to help advise on our gestational diabetes patients, because the numbers of gestational diabetes are much higher. And also Fareeha's expertise on the endocrine disorders. So with regard to thyroid disorders, like pituitary problems. So we look at more at some women who may have had pre-existing endocrine problems prior to getting pregnant. And then we'll try to deliver care which encompasses both the endocrinology aspect as well as what that means for the pregnancy. So that's where I would come in as an obstetrician. And so ultimately where I am at, I'm a consultant obstetrician and gynecologist in the East London Hospital. I work in the NHS and I lead on diabetes and pregnancy. And also I would see all the women with endocrine disorders in an antenatal clinic. So that's where they'll see me. So I think what it is a lot of joined up care, and we try to get experts in the room to just try to tailor the plan at the center of it is the client or the patient. So that's where we would work together. So we used to work together and would love to work together in the future, but that's where we'd work together to try to make sure pregnancy was as smooth as possible and the outcome is as good as it can be.
Fantastic. Thanks for you both. So obviously for anyone listening in that is suffering from gestational diabetes or is concerned about it, they can get a really good insight right from the very top. So today, the journey for today, we're going to step through. One, I'd like to hand over to you guys to provide a little bit of context and maybe definitions, because people might not be aware of what exactly is it. And we'll set the scene for today. Like, what's the problem? What are some of the impact stats? Why should people be concerned about this condition? And then we'll step into what can you do about it? And that's going to take two paths. We'll look at what can we do to either prevent or be proactive in dealing with these things, and maybe what can be done that is less non-medical interventions. And then we'll look at actually when you do have these issues or it's gone further down the line, what can be done medically. And we'll look at those two different paths. So that's the journey we'd like to take today. So maybe let's take a quick pause and say, well, yeah, what is gestational diabetes? Why is it an issue? And why should people be concerned about this?
Yep. So gestational diabetes is where blood sugar abnormality, the first time is detected, is in pregnancy. So high blood sugar, according to some international definitions, which has been detected for the first time in pregnancy. So a woman has not been aware of any blood sugar abnormalities or diabetes before pregnancy, but because of certain high risk features, maybe family history, ethnicity, age, previously having a big baby. At the booking appointment, those risk factors will have been highlighted, and then a woman will be sent for what we call a GTT, or a glucose tolerance test. Depending on certain factors, she may have that GTT a bit earlier in pregnancy. Usually it's between 24 to 28 weeks. And then the results of that will determine if a woman has gestational diabetes.
So the reason why they test for it around about that third trimester is that's when insulin resistance goes up. So the pregnancy hormones can cause someone who's naturally doesn't have diabetes outside pregnancy. That's what sort of brings out the diabetes in them. And so typically that's when it happens. And I guess the other thing is that sometimes it happens a lot later. You might not pick it up on that initial test, but you might see other signs of it, like when they dip the urine, there's a lot of sugar there. Because there's a lot of sugar in the system and they're trying to pee it out. So that might be an indication to test for it. Or say they're suspecting there's a lot more water around baby, or if baby's measuring big. So it's a little bit difficult because like scans are notoriously not 100% accurate. And when the baby measures big, it may just be that baby's constitutionally big, but it can also be a margin of error because you're taking all the measurements through mum. But sometimes when we look particularly at baby's tummy circumference, and that's measuring bigger on like a scale as such, that might push us towards thinking, could this be because of diabetes in pregnancy? So yes, there are lots of, just so that women know that it's never like a textbook definition, and they have the test and it comes out that way. So it can come out in other ways. And I just want to say that it differs. And the whole reason why we test for it is that if we do identify it and we address it as well as we can, and sometimes this is not by medication, it's by something that Fareeha champions very much for, like the dietary and the lifestyle interventions, it can really improve outcomes for mum and baby. So screening tests, most people are offered it. Not everyone is offered it, so just bear that in mind.
Okay, great. So this may be the first time that many women come across the fact that they might have diabetes. Now, I'm going to ask a stupid question and say, well, why is this a problem? What problems can it cause?
Well, that's a great question. And that's probably the first thing that the individual woman probably, thinks. It's the first question that will come to mind. So gestational diabetes can be thought of as a warning sign for an individual's susceptibility to diabetes in later life. So I see people in pregnancy, before pregnancy and after pregnancy, obviously. And if a woman has had gestational diabetes, there are increased risks to her future metabolic health. So things like increased risk of type 2 and, interestingly, type 1 diabetes in later life, increased risk of heart disease, kidney disease, lots of different cholesterol, lots of different complications that we tend to think of as disease of older people, we are now seeing in younger people, and particularly women. So gestational diabetes is a bit of a warning, a bit of a herald that we need to think 10, 20 years into the future, because there is an increased risk of all of these problems in an individual who has had gestational diabetes.
Mm-hmm.
That's so interesting, because I think we had a few who had gestational diabetes and then were later diagnosed as type 1 diabetes. So we all talk about type 2 diabetes being a risk factor. So that's really interesting that you're saying that more type 1 diabetes are
type 1 because of the immune changes that happen in pregnancy. It's thought to be, because a woman's immune system undergoes so many different changes in pregnancy, it's thought that probably is the reason for why some women develop type 1 and not type 2 diabetes. What I will clarify here is the difference between type 1 and type 2. So essentially, type 1 diabetes is where an individual's pancreas stops making insulin hormone. Insulin is a hormone that we need to exist. Without insulin, we would die. It's a hormone that comes from the pancreas, and it is a very clever system that when our blood sugar rises, the pancreas knows just how much insulin to make in the correct quantities, in the correct amount for, the correct amount of time, and our blood sugar comes down to a normal range. Never too high, never too low, if the system is working correctly. Type 2 diabetes is a much more complex condition, which is essentially end stage insulin resistance. So Fiona mentioned insulin resistance. Insulin resistance is a complex syndrome, so a complex collection of symptoms that an individual may experience, but basically it means that we're making too much insulin and the insulin is not able to control the blood sugar anymore. So you could think about type 1 diabetes and type 2 diabetes as slightly opposite. The problem is insulin, but in type 1 there's no insulin because of immune system damage to the pancreas. And in type 2 diabetes there's too much insulin, but the insulin isn't working anymore.
Got it. Thank you for that. That's a very helpful, clear definition. Now, one thing that occurred to me, like growing up, I had lots of peers or my aunts and uncles that had diabetes, and I grew up hearing this quite a lot. And it kind of occurred to me that I didn't really think of it as like, well, it's just you're diabetic, and you hear this quite often. And it was a conversation that struck me the other day, Fareeha, where you mentioned the gravity of diabetes, which never really occurred to me. So maybe we can just go there and talk about, this isn't to scare, but it is to articulate the severity of it. And then I think we'll talk about what can be done about it, because it's not just something to live with. But please share a bit more of insight around that, because that really knocked me sideways.
Well, this is the thing. So I think lots of people just have the same kind of relaxed view about diabetes, maybe because we all know somebody with diabetes. Maybe it's that. So both my parents are diabetic. I think 3 out of 4 grandparents of mine were diabetic. One of my grandmas, she died on dialysis. She had kidney failure because of diabetes. So, and all of my aunts, so many of my uncles, they all have diabetes. So maybe that's why, because we all know someone living with diabetes, that there isn't that same sort of gravitas that we think about. We don't think about it in the same way. Certain cancers have better outcomes than diabetes does. So certain cancers like lymphoma, other cancers are completely curable. Diabetes we've only ever managed to achieve remission in diabetes and not actually cure it, because the genetic tendency to diabetes stays with you your whole life. So if I could choose a disease, I certainly wouldn't choose diabetes, because it has so many other complications. You've heard about heart disease, stroke, amputations, nerve disease. It's the leading cause of blindness in the Western world. It's the leading cause of kidney failure and people ending up on dialysis and kidney transplant. So really, if diabetes is not well controlled and it's not well treated, an individual can have a really miserable life. And I'm so glad that in the last 10 to 15 years, diabetes therapy and education has really improved, that we're hopefully seeing less of those outcomes than we did 20 or 30 years ago. But still, on one side, we have better drugs, we have better education, but on the other side, we're seeing people being diagnosed younger and younger with diabetes. And that's because of the modern food environment and the interplay between modern life, food, and genetics. So it just seems like we're constantly chasing our tails when it comes to diabetes. And like I said, I could talk about this all day, but again, I think people do need to appreciate the severity of diabetes, particularly if they're diagnosed young, as many of our viewers will be, that it is something really to take seriously.
Yep.
I definitely agree with that. And I think the key message I would very much like is that, as we often say, is that pregnancy is a window into a woman's future health. And these are probably the stages. And I definitely have seen some women, because I see all the women with gestational diabetes. And sorry, you were asking about the prevalence. It's probably in my unit, so in a district general hospital, probably about 9% of the population. But then when you see that population in my clinic, they often are of like an Asian ethnicity, especially our type 2s as well. But it's at a stage where it's almost like a warning sign, and you're at like a crossroads perhaps, and you can go down one road where you really try to prevent yourself from getting it in the future. And we're definitely at a stage where you can definitely do something about it, or you can monitor it, closer surveillance, things like that.
Yeah, that's really helpful because that really startled me when you mentioned that, Priya, because I think the severity of it, because you're saying you're almost desensitized because everyone knows someone with it. So it becomes, it's not a big thing, or seemingly when you hear, oh, I'm pre-diabetic, etc. So, but I think the important point, as you mentioned, Fiona, is as severe as this diagnosis is, one, there's things that can be done about it, particularly like if that radar warning on the dashboard shows up, as you would identify, it can be preventable and it can be reversible to an extent, depending on when you catch it. So I think the key take home, particularly when we're talking to pregnant mothers, is that this is the warning sign to do something. And that action can have significantly positive impact if the right behavior change begins. And that's probably the hardest thing, I imagine, as clinicians, is the behavior change. Is you can tell everybody how serious it is, but individually, once you've left the clinic, how does behavior change take hold? And maybe that's probably where we can maybe go next to thinking about, we've talked about the impact and the diagnosis and the way to understand that if you do or don't have it. Where would you typically go with someone that presented with these, with these symptoms or this diagnosis? What would you advise them in the first instance to start thinking about? Where do we start?
So it kind of depends a little bit on the woman sat in front of you. So if she is maybe older, if there's a really strong family history, if there has been overweight or obesity at the time of conception, it depends a lot on lifestyle and dietary habits as well, as to how we tailor advice and behavior change, because and it also depends a little bit on the blood result as well. So you have the blood result in front of you, then you have the woman in front of you, and then you look at the blood result and you kind of get a bit of a feeling after a few years of experience that actually this woman may be okay with just dietary changes, and the blood sugar is not that high, and it should hopefully stay under control until the end of pregnancy. But then in some women, if they've got other factors like Fiona mentioned, ethnicity or age, or they've had multiple children before, they've had gestational diabetes before, then you kind of get a feeling that actually dietary changes, although are crucial in every woman, maybe dietary changes alone are not going to suffice. And so in those women, I would start something like metformin, which is a really good drug to help combat insulin resistance. It treats insulin resistance. So we can start that pretty much at the first time when they meet me, because it's harmless, generally speaking, very well tolerated, side effect free. And there have been lots of studies on metformin, and it's been proven to be very safe. There was some concern that it may be size, but actually those studies have now been disproven. So because if we don't use metformin, the only other drug that we can use is insulin. So most women will prefer to do diet and lifestyle changes and metformin for as long as they can. I'm sure you agree, Fiona. I'm sure you see something similar. Although I have to say, in my clinic here in Dubai, 20% of pregnancies in the Middle East, 20% of pregnancies are affected by gestational diabetes.
20%.
Yes.
Wow.
Yes. It's
Okay.
extraordinary. Yeah.
Yeah, it definitely ranges, and I think the range is around about 8 to 24%, and globally it is about 25%. I think it's a very prevalent problem. Yeah, no, I totally agree. So we usually would have this joint clinic with obstetrics and endocrinology. So I rely very much on Fareeha and dietitian advice for the person sat in front of you. So totally, if they have glucose tolerance tests, or we also check the HbA1c as well. Again, it differs from unit to unit, but those who have risk factors would have a blood test, which is a mark of their sugar control over the last 3 months. So if it's in the sort of pre-diabetes range, most units will consider them as like having gestational diabetes because it's so early, and that was at conception. And as insulin resistance goes up, so it's probably better to put them on that pathway to monitor closely, just because we know that if they can monitor sugars regularly, so it's using a fasting sugar and 1 hour after each meal, and to see and keeping them in a really tight range, so a bit stricter than outside of pregnancy, it can really optimize outcomes for mum and for baby. And for me as an obstetrician, wanting to make sure baby's growing okay and steadily. So we would recommend like extra growth scans to see the trajectory. But also, so there are implications in terms of like, if sometimes I see about like maybe about 10%, the babies are actually quite small grown. The reason why we think that baby would be large is because insulin, the high glucose levels in mum would go over to baby. And baby will then try to secrete their own insulin to lower these glucose levels. And insulin itself is a growth factor, so that might accelerate baby's growth and make baby larger. So typically people think of diabetic babies as being quite big, and sometimes they can deposit the fat because in areas such as like near the shoulders or so. So we worry about baby being quite big and about labour being affected. So you might not be able to successfully achieve a vaginal birth, and sometimes if the baby's head comes out and then the shoulder can get stuck. So I worry about those things, and what I'm trying to do is trying to optimize things to try to prevent that. And sometimes we may suggest that they might need to deliver before they go into labour spontaneously. So a lot of women really don't like having induction of labour, which is giving them medicines to go into labour because it's not natural and it can take a long time and it may not work. So I guess all throughout, I rely on like the diabetes advice to optimize their glycemic control, but at the same time trying to see how mum and baby are. And there's very clear recommendations around timing of delivery in pre-existing diabetes and say gestational diabetes, where it's just controlled by diet and exercise and there's no concerns with baby's growth, because we've got very clear data on the risk of stillbirth, so baby passing away before baby delivers. So most of the time we'd be recommending an earlier delivery, maybe up to 40, so by 40 weeks and 6 days, so 6 days with the due date for gestational diabetes, and that's relatively well controlled, and then by about 38 weeks and 6 days for those with pre-existing diabetes.
Got it.
So that's where we come from an obstetric point of view.
I'd like to come back to a couple of points that you both raised. Fareeha, you painted this picture of there'll be a group where there is an element of control that you can do things about this, and there'll be a group that is uncontrollable where you need to then seek medical intervention like metformin. Now, in that second bucket of people, there'll probably be a population of people that are resistant to having any medication. And I just wanted for you to have an opportunity, if there's people listening in and say, you know what, I I don't know what's going on. I hear there's some issues, but I really don't want to have any medical intervention. I want things to be as natural as possible. Now, obviously, you've articulated some of the issues, but what would you say to that person to help allay some of the concerns, or why that would be, a productive way forward? How would you handle that conversation? What would you say to them?
Yeah, I always try and have the most open conversations with all of my patients, all of my, women that I see. And pregnancy can be a really scary time. I'm a
Mm,
mum. I've got 3 kids.
mm,
I was terrified in all of my
yeah.
pregnancies, and I was a doctor for so many years. So I understand. And I always try and put myself in the woman's shoes. But at the end of the day, we are here to help. I'm not here to ruin anyone's pregnancy experience or to negatively impact anyone's, emotional health. The best that I can do is just lay down the statistics. And as long as the woman, is compos mentis and she has a capacity to decide, then she's free to, make her own choices around birth.
Mm,
We will support her the best way that we can. So if there's any way that we can help her with her appointments, checking more often, getting a glucose sensor. A lot of women are needle phobic. So there may be lots of different aspects of anxiety related to pregnancy and then birth and delivery.
mm,
We will always try and support. I do recommend medication. Like I said, I will give them the pros and cons, and I will offer, if someone's particularly anxious, more often appointments. If they don't want to
mm,
take medication, we might have a joint appointment, like we have done many, many times in the past with Fiona and myself, to try and allay any fears. We'll get family involved wherever needed. So there's never one size fits all. And I very rarely, to be honest, lay down the law that you have to take this
yeah.
medication. This is absolute. This is the law. I don't tend to do that. It's not fair to do that. The best you can do is just give someone the statistics. None of us are God. We don't know what is actually going to happen, but we can give our best expert advice based on the hundreds, thousands of women that we've looked after.
Great. Yeah, that's very sound. And that's great to hear, because we talk a lot about, self-advocacy.
Yeah, of
How
course.
do we empower people to make their own decisions? Obviously guided by the the experts such as yourselves and the data that is provided around your scans. But ultimately, how do you feel comfortable and confident in your own decisions? And I think it's great to hear that how you work with the mother to come to that conclusion. I wanted to then switch over to the first category where you say, hey, you know what, it is controllable, and to explore what are those key levers, what are the main buckets of things. You've mentioned things like eat, sleep, exercise, and I wanted to kind of go into a bit more detail. So for people that are listening in, say, well, if I wanted to optimize my health and be as proactive as possible, what would the top key things you would talk about? Well, what would have the biggest impact within my control? What would those be?
So eat, sleep, and exercise are so important. And those are the 3 things that go completely haywire and bonkers when a woman
Yeah,
is pregnant and she's a
yeah.
new mum. And again, I was a new mum during my training 3 times. I know how difficult it is. You can't eat properly. You certainly can't sleep or exercise. But again, something I tell my clients, my patients is, even a 10-minute walk is better than no walk in a day. If you
Mm,
are going, for example, about eating, there's good evidence that something called the diabetes healthy plate, that can help a
mm,
lot with blood sugar control. So basic things with regards to eating is to cut out sugar, unfortunately. So that's like ice cream, cakes, biscuits, sweets,
all
sugar,
the good stuff.
all the good stuff, all the things that women crave, and maybe swap even fruit. Maybe I ask women actually to maybe lay off fruit for a few weeks and replace that with vegetables. All the nutrients that you get from fruit, so the vitamins, the minerals, the fiber, you can get from vegetables without sugar, without fructose. So I say, half of your plate should be vegetables. That can be a salad or cooked vegetables, a stir fry, or even a curry, homemade, ideally, if possible, with less oil, no sugar, and little salt. And then a quarter of their plate should be protein. And the rest can be a small portion of carbohydrate. And that should ideally be unprocessed, unrefined, whole grain carbohydrates. So brown rice, brown pasta, quinoa, couscous, something like that. Women do need carbs. We all need some carbohydrate to get us through the physiological demands of pregnancy. It's tiring to be pregnant. If you don't eat carbs, you will be exhausted. So basic things you can do with your diet. It doesn't require calorie counting, or it does require maybe a little bit of attention to portions, but I never recommend strict portion control. And then sleep, you should sleep as much as you can, particularly if you're a first-time mum, then you're not going to sleep. So you should sleep. Sleep really positively affects our insulin levels, our stress hormones, our hunger hormones as well. So when we don't sleep, whether we're pregnant or not, all of those hormones go haywire. So sleep wherever you can. And like I said, a 10-minute walk, 15-minute walk, maybe after your bigger meal of the day is the best thing to lower blood sugar. If you can, have your bigger meals earlier in the day, so breakfast and lunch. And if you're not, then you'll be less hungry at dinner, and you'll maybe avoid overeating at dinner. That's something that I see quite commonly. So if you're well nourished with good amount of protein and vegetables earlier in the day, you will find that actually you don't need to snack, or you don't need a big meal in the evenings.
Great. Can we talk a bit about the impact of those good habits? Because obviously, as you said, I'm glad you called it out, which is like sleep, eat, and exercise is probably the hardest thing you can do. So to give people the inspiration to make that effort, talk about some of the success stories that you've seen where people have followed that kind of advice. What kind of results have you seen when we talk about it being preventable and reversible? How much can someone impact their own health by doing these things?
Really dramatically. That 40, I think up to 40% of women can control their gestational diabetes with diet alone. In some populations, it will be even higher. In some populations, it will be lower, but on average, so that's almost half of women can control it through diet and lifestyle. So, and then they have a better chance of, a lovely birth the way they want, with the help of someone like Fiona, because that's where I tend to chicken out. I tend to chicken out around the time of delivery. But recently I had a woman with gestational diabetes, and she had a lovely birth at 40 weeks. She was diagnosed with gestational diabetes around, I think, 27 or 28 weeks. And the other thing that's very powerful is just coming to your appointment. So if you don't want medication, you don't want a very medicalized care, but as long as you come to your routine appointments regularly, so that we can check in with you and see how you're doing, because we also want to identify where women might be struggling. So this woman was a perfect example of that, and she had a beautiful birth and had a very lovely, healthy baby, just through diet and lifestyle alone. So it is entirely possible, and that's what we want. We don't want women to have a very medicalized birth or delivery. I mean, I'll let Fiona take over because Fiona's the surgeon. I'm not. But no, we don't want to see our women hooked up to lots of drips and having loads of injections and things. No one wants that.
Yeah, absolutely. And so luckily I can say that in the unit I work at, it's probably about 60 to almost 70% will just manage their diabetes by diet and exercise. And actually they won't even see me because they have a nice, lovely delivery by a midwife. So I think in the UK, most deliveries are by midwives, especially if they're very straightforward vagina births. And obstetricians like myself would come along if there was a problem, and I might help with an assisted instrumental delivery or a cesarean delivery if necessary. So yeah, you can definitely do that. And I think sometimes you're never going to find a volunteer to say for like up to 9 months of my pregnancy, I'm going to check my sugars as soon as I wake up and 1 hour after each meal. Nobody is ever going to do that, but women will do that to optimize things for their baby. And that's probably the best test, because everybody is like, my daughter always says this, it says everyone's unique. They are unique because the way they process their food and the different types of food, because they could eat something that they think is really bad, but it doesn't push their sugars up as much. And so they sort of like do a trial and error and just basically see what works for them. And so by the end of that time frame, they know what pushes their sugars up. Obviously, once they've had the baby and that those pregnancy hormones have gone away and the insulin resistance gets better, things will get better. But as Fareeha mentioned, that risk is always going to be there. They're always at risk of developing type 2 diabetes. So in terms of success stories, I have seen some women who have either had type 2 diabetes or gestational diabetes. And I would say trying to keep weight stable, because I've had two babies before and it's so easy to gain weight in between. And I totally understand, like, once you've had a baby, you're just trying to process everything. You're trying to just survive. So I'd say just be kind, and it doesn't mean you have to do it straight away, but trying to slowly get back to the healthy eating habits, and where you can sleep as long as you can, because it's very hard to do that in the first stages. But when you try to slowly just take one step at a time, and I think it's really good how Fareeha said, even just 10 minutes, just 10 minutes of walking, just when you process that as little, like, changing habits are very, very difficult. But if you just feel that you've achieved something by doing one little thing each time, and hopefully building yourself that way. So the success stories are seen when women go back to either their pre-pregnancy weight or try to optimize to get to their best physical weight. And probably more with that is the insulin resistance that comes from maybe fat stored around the waist. So the waist hip ratio, I think, is quite informative, probably better than body mass index, which is routinely used as a measure of how overweight someone might be. Or but when you do that, it can really optimize health from, I guess, metabolic disease in the future. The exercise also does help with mental health. And just then, when I meet them in future pregnancies, and I have met some of these women, their sugar control, their glycemic control is much better, and they don't always get diabetes again because some of those risk factors have lessened. So I've definitely had a lot of type 2 diabetic women who have been very motivated. And the next time I've met them, their HbA1c is much better. I do have some the other way where it's much worse, but it's so reassuring to see the ones who've really improved their glycemic control. And they know that if they do this, like the healthier eating, exercising, sleeping well, their children and their partners will see it. So it does affect the whole family, I feel.
Great, great. That's really helpful. Thank you both. And I'm hoping what we've done in this conversation is, one, to make people more aware and familiar with the risks of diabetes, because again, it's so commonplace, and to understand actually it's very severe and what the impact is on, both before the birth and after the birth for the mother. But at the same time, paint a picture of there is a lot that can be done, both within your control and when it's not in your control, what can be done medically. So I'm hoping that provides some hope and inspiration for people that are suffering with this or might get diagnosed with that. I wonder if we can wrap up then with, one, are there any key resources or where they might want to find out further information that you would want to highlight, whether that's at a UK level, global level, etc.? What are some of the great resources that you guys would advocate that people go to find out more? And then secondly is just, again, probably just what are the key take homes from this overall conversation? There's a lot here. I'm sure we could talk much more on it, but again, for someone that's just getting their an understanding of this area, what would be the key things for them to make sure they take home from this conversation? So let's talk, first of all, resources. What are some of the great things out there that people should go to find out more about this?
Well, in the UK, Diabetes UK absolutely has great videos, patient stories, patient journeys related to diabetes in pregnancy and gestational diabetes, type 1, type 2 diabetes. Real people that are sharing their experiences on there. They also have meal plans as well, and multiple healthy eating guides. So Diabetes UK, it's free. It's free for anyone to access all over the world. It used to be a paid charity, but it's now free. All the content is free. So that should be the first place where people could go. And also relatives, family members, partners, husbands, wives, anyone can go there and have a look. And the key take-home message, I would say, is number one is the diabetes healthy plate, like I mentioned. That should be your starting point for eating. And then number two is just try and find a doctor that you trust that you can engage with and that you can come to the appointments with, and you feel heard, and you build a relationship, because actually that's really important. I have lifelong relationships with a lot of my people with diabetes. I've looked after them for a long time, and I think a doctor that knows you well really is really key.
Fantastic. Thank you. Fiona?
Yeah, no, that's really good. And I think in the UK, the diabetes prevention program, so it's by NHS England, it's free of charge as well. And the website depends on where you live in the country. And so I think in East London, it's healthieru.org.uk. And what we can do is probably signpost with this podcast and the other links to useful resources. It's basically a 9-month program, which is free of charge. They get a one-to-one call with a health coach, and then 13 group sessions online with other women with gestational diabetes. And there's sort of like monthly interventions. They get access to exercise programs online. So depending on the mobility, they might have like armchair aerobics, Tai Chi, high intensity interval training. And also they've got some resources for hacks for certain recipes to make them more diabetes friendly, and also a journal template, because you're more likely to sustain a habit by keeping a journal of what you're doing. And it's all free and very easily accessible. If you had gestational diabetes, you can self-refer. I think you just need your NHS number, and then you can refer into the program. I think so. They've published some data on it, and about 37% of those who engage in the program will prevent themselves from getting type 2 diabetes. Because what I think we haven't mentioned is that for those who do get gestational diabetes, in the next 5 to 10 years, they've got a 50 to 70% chance of becoming a type 2 diabetic. And so I think definitely if you engage with a doctor who you would like to help support you on this journey, you can really reverse this. So reversing your risk and reversing early type 2 diabetes before it gets quite like progressive and more complications. Mm-hmm. One of my questions I had for Fareeha was because we've talked a lot during this episode more about gestational diabetes, but if we're focusing on women who've had their babies postnatally, as a diabetologist, other than these sort of like lifestyle, what would you recommend for women to really try to optimize things? So finding someone, a trusted doctor, is there anything else that you would recommend, especially in that first year, to optimize health?
So the biggest thing that I talk about in their postnatal follow-up is obviously we do blood tests, and with the blood tests in front of us, we have a frank chat about how things are going. How are they eating? How are they sleeping? Are they managing to do exercise? Are they recovering from a C-section? How is their pain, if any? And we'll always discuss that. Also, if they're breastfeeding has multiple benefits for mother and child, and that can help protect both mum and baby in terms of future risk of disease. That's a separate topic in itself, but I will take into account the fact if mum is breastfeeding. And then we talk about, as you mentioned, the pregnancy weight gain. How much was the weight gain? And if there has been any post-pregnancy weight loss, has it been healthy weight loss? Has it been gradual weight loss? How is the hunger? Hunger can also be impacted by breastfeeding. So we discussed multiple different things. I've had a few women recently who have asked for GLP-1 medication post-delivery. And again, that's a completely reasonable treatment option in the appropriate woman. So there's multiple different things that we can offer women in terms of getting them back to a healthier state. But always we start with diet and exercise because we want to use the thing with the least side effects, right? So we want things that will do no harm. And that is basically diet, exercise, and sleep always. And then I'll offer them 6 to 12 monthly blood tests. So that's what I'm currently doing. And just me being able to kind of lay eyes on them and see how they're doing, even just that can really, really help. So it's never one size fits all. There's multiple treatment options, but I think the key is engaging and kind of keeping an eye out for any problems before they develop.
Great.
That's so good. Yeah. No, because I think it's so helpful. They should also have this annual HbA1c check, if not 6 monthly. And what's considered normal in the UK might not be considered normal outside of the UK. So I think it's so important for women to know what's normal for them.
Yes.
So if they've always having an HbA1c of say 36, and then suddenly it starts creeping up each time, it's going up to 39, then it's going up to 40, you know it's moving in the wrong direction. And so for them, a 39 may be normal on paper, but it's not normal for them.
Great. Thank you both. This has been a really informative conversation. And I think, what's clear from the discussion is there's far more than this short discussion, but hopefully there are some very clear take homes if you're listening and that might be suffering from this. And I think the importance, as you mentioned, of appreciating the personalization of each of these issues, right? And finding, as you're saying, the right doctor for you and the the path that's right for you. I think that's really clear, as opposed to everyone following the same thing. So whilst there are some common principles, it is about finding something that works for you. And I think that's just really helpful to hear from both of you. So I think that'd be great to think about wrapping up this discussion for now. I know there's plenty more, but just want to say a huge thank you to you both. Again, we'll signpost the resources. Fareeha, where can people find you further if they want to get in contact or find more about what you're doing?
My website is fareeharizvi.com, and my social media page where I post every day is Diabetes Care with Dr F Rizvi. It's on Instagram, TikTok, YouTube, Facebook, and LinkedIn.
Wow. Everywhere there. That's great. Couldn't think of a better person to speak to about this. Thank you again. In the next conversation, we'll talk more about obesity and the impact that has and how the link is with diabetes. But again, thank you both for this conversation.
Great. Thank you so much.